So I'm going to stop sharing and hand over to you now, Justine. Just to introduce Justine before we get started, Justine is a consultant, allied healthcare professional and clinical academic working at the University of Manchester and Manchester, primarily Manchester University NHS Foundation Trust. She has over 10 years of experience working in research, where she first started as a local collaborator before moving to PI status and completing her PhD. She has held several awards, including the NIHR and Manchester University, from the NIHR and Manchester University fellowships. In her clinical academic role at MFT, she is the lead research champion for allied healthcare professionals across the whole organisation. I'm really excited to hear from you today, Justine, and can't wait to hear what you have to say. So take it away.
Thanks, Jude. Can I just clarify, just confirm what time we're due to finish, just so that I can schedule my timings? I'm not sure if we've had a diary query.
Yeah, so we aim to finish at about 11:45, but I'm aware that due to a bit of a bumpy start, we may go slightly over, but this will be on YouTube. So if you're joining right now and you know that you need to go sooner, you can always pick it up there and we'll send you the link.
Fantastic, thank you. I might just skip over some of the slides just in the interest of time, so we'll see how we go. Welcome everybody. Apologies for the rocky start. We all love a little bit of Teams, little technical glitches, don't we? But here we are. So thanks very much for the introduction, Jude, and really appreciate the opportunity to share my experience and my research career so far. So thank you so much. And I plan to illustrate how working as collaborative teams and reaching out and looking at the landscape more widely can really help us pull together and overcome barriers and challenges, which not only benefit our patients, but also hugely benefit us as clinicians and the wider organisation to improve patient care. So this is me. This is my background. I started as a mature student in 1998. I graduated from the University of Leeds, and then not long after joined MFT and was appointed as a clinical lead therapist in trauma and orthopaedics. And within a couple of years, I decided to progress to do my advanced clinical practitioner. I was very much a clinician, didn't really want to consider going into a managerial route. I was very much a clinician. So I decided to do my ACP masters. I was incredibly surprised to be successful to the level of a distinction in my masters. Not only was I surprised at that, but I was also given 2 awards. One was a special recognition award for outstanding academic and non-academic contribution. And then the other award was the Dean's Award for an outstanding thesis titled "The Introduction of an ACP in a fracture clinic." So, and this looked at the impact on services, but then on also patient experience. And this was an audit. And the really impactful thing with this piece of work was that we went from having 160 patients in a Monday morning fracture clinic down to 20 patients. And that was solely because of the way that we relooked at the whole of the service that was being provided. And we put the right person in the right place at the right time. And it had a huge impact on patients that had gone from waiting, could have been 6 hours, sometimes patients are waiting in fracture clinics to be seen, and went down to 15-minute waits. So not only did that have a significant impact on patients and the service and everybody else around us, it personally had a huge impact on me, because it just made me feel that I didn't feel like I did an awful lot. I put the work in, but it had such a huge impact, and that was really powerful for me. So what I did, I took that mindset and that I was buoyed, I was full of enthusiasm. So I took that back to our trauma and orthopaedic team and looked at other opportunities whereby we could improve patient care and our patient experience. So we reviewed the KPIs and the metrics of MFT as an organisation on the delivery of hip replacement services. And we've been historically an outlier nationally on the National Joint Registry data set, where we were really long. Our patients were staying with us for a really long time. So our length of stay was 13 days compared to the national average of 7 days. Consequently, our patients had really long waiting times for surgery. So our patients were waiting 56 weeks compared to 26 weeks as the national average. So we were really embarrassed by this. As a clinical team, we were mortified. So it gave us a real initial driver for change. So we had that one vision and a shared vision that we wanted to improve this. And then not long after that, 2010, when we were thinking about how we're going to change this service, the NHS England launched the enhanced recovery pathway. And when we looked at that, I just happened to drop into a session in a conference where they launched it, took it back to the organisation, and we reviewed the recommendations, and it was just put in the too hard to do pile. It was just enormous. And from where we were and where we needed to be, it was going to take an awful lot of work. So it was just put to one side. But we went back and we audited against the standards using the enhanced recovery pathway. We looked at the GIRF, so getting it right first time standards, and we also looked at the BOA standards. So this was now 2011. We then identified the barriers of change, and we looked at change models for, again, used by NHS England. So this is now taking us to 2012. And you can see we've just got, this is a mountain, and we started in 2011 and we just gradually climbed to the top of this mountain, and it was a big team effort. Some of us were carrying pretty heavy backpacks, and some were just along for a bit of a ride, but it was a monumental journey for us all. We looked at pathway co-design, and we did co-design not only just with us as clinicians, but also we brought patients in and we brought carers in, and we co-designed our new pathway. And then we re-audited in 2013. We then went back again and we reviewed the barriers that came through from the re-audit. And again, we used some of the similar methodologies, and we did scoping and process mapping. And then we did huge stakeholder engagement for the whole of the wider stakeholder group. And we looked at everybody's engagement and experience throughout that engagement. So the findings and the pretty much the barriers that we came across during this stakeholder engagement, that we anticipated would launch us to the next stage for us. We looked at clinicians, and then we've broken them down for patients and carers. And many of our consultants refused to get involved with the enhanced recovery programme. They said it was enhanced discharge. They felt that it would increase the risk of complications. Things were not broken, so why did we need to fix it? Well, we could argue that they were actually broken. The anaesthetists were concerned about carbohydrate loading, which is a clear fluid before taken by patients 2 hours before surgery. So there was worries about aspirations and complications. There was a perceived threat to professional roles and job satisfaction, particularly with therapy and nursing. And there was a lot of concern about patients feeling, clinicians felt that patients would feel that they were being kicked out and they were sent home far too early. There was worries about hip dislocations because patients would go home, they wouldn't be able to cope, and they'd do too much too soon, which would increase the readmission rates and also have an impact on long-term outcomes. So that was the clinicians' perspectives. From the patient and carers' perspective, they felt that they needed a longer stay in hospital to recover. They were worried about if something went wrong when they were at home and they couldn't cope. They were worried that they would become addicted to analgesia, which is a real life concern for us all, really. And they were worried about having nausea, because quite a number of patients complained of nausea when they used opiate analgesia, and also constipation. So these were concerns particularly of patients that then when they went home, they wouldn't have any support around them to actually help them because GP access was quite limited. So these were real challenges that we needed to overcome with our work, which we did. Again, patients in the centre of it, and then all the relevant key stakeholders were feeding into that, and we had that shared purpose, and this was our mission. And we were aiming for that, the peak of the mountain. So what we identified was then in 2011, when we re-audited again in 2013, we had significant changes. So our length of stay was reduced to 5 days. Our waiting time for surgery was down to 22 weeks, by which time the national average was 24. So we were actually better than the national average. And then all the other metrics you can see there, particularly local infiltration, antiemetics we introduced to avoid that nausea that patients were worried about. Carbohydrate loading, all of patients had that at 100%, and that's to reduce that dip and the blood sugar after surgery, which can have huge implications. And then the opiate sparing analgesia we used again for the reasons that patients were concerned about. So we had huge improvements, to the point that we were awarded 2 Health Service Journal Awards, one in 2012, and you can see the feedback there, and then we had the second one in 2013. And the general theme there was it was a team approach, and not only did we involve the team, but we also had patients that were in the centre of it as well. and they could see the passion for improvement was evident. Then it was what next? Our patients, when we were doing all the engagement, our patients were telling us that these HIP precautions that they had to follow for some 6 weeks and some for 12 weeks were not helpful. It hugely impacted on their sleep, their quality of life and their function, and they were quite miserable having to follow these. Some of them told us that they didn't actually follow the recommendations that we were suggesting, and they discarded hugely expensive equipment that were provided so that they could follow the precautions, which was simple. Not allowed to cross the legs, they had to sleep on their backs, they had to have high raised chairs, they had to have their beds raised, and the equipment that was provided was quite often discarded and put in the garage for quite some time. And immediately as soon as they were going home from hospital for 4 days, and it would just stay languishing there for years and never return to the hospital at huge expense. The other thing that we found that we couldn't really reduce our length of stay any further because patients needed to adhere to the precautions before they actually went home. And we were finding that for them to adhere and be able to function safely, it was taking us the 4 to 5 days, and we weren't actually going to reduce that any further. Again, the surgeons didn't want to change. They didn't want to change the precaution recommendations, again, for the fear of dislocation, which is the principal reason why they are endorsed. So we were stuck. We'd used all the methodologies, which are all very intrinsically linked. We'd used the methodologies at our disposal, and we couldn't actually make that next step until we were brave and decided to step into the research arena. So this is where, 2015 we were at this point. So we did a literature review and we explored the impact of precautions on dislocation rates, which, as I say, is the reason for their use. The results were very inconclusive. The evidence was very weak. There was no systematic reviews or meta-analysis because there were no RTTs. So there was nothing that we could actually hang our hat on and say that this is the way we need to go. We knew anecdotally that some patients were not adhering, and those that didn't adhere didn't seem to dislocate any more frequently than those that were adhering to precautions. So we started to scratch our heads and think, do we actually need a trial? Who's going to be brave enough to do this? And canvassing the experts, it was like nobody, because the sample size is 4,500. This is on the too hard to do pile without a shadow of a doubt. So it just didn't get done. So I then stepped into the MPhil. We did a prospective cohort study looking at self-reported adherence questionnaires and patient diaries just to actually see what patients were telling us, because if they weren't doing the advice, following the advice anyway, then could we really justify doing a big expensive trial? So we used quantitative and qualitative analysis during this study. And we found that 32% of patients were not actually adhering, so they weren't following the advice once they went home, and that was at 4 days by this time. There was no difference in dislocation rate between the two groups either. We had 68% of patients said that they had great difficulty getting back to the usual activities. 73% felt precautions slowed down their recovery. 65% only 65% used the equipment, and the others removed it as soon as they were discharged from hospital, as we suspected. 68% reported adherence to supine sleeping, so that's sleeping on their backs, and the others just chose to sleep as they would usually do anyway. And 95% of patients felt that a trial would be of great value. So at this point in 2017, I unfortunately lost the funding through huge changes over at the University of Manchester, and my funding was no longer available to transfer from PhD, from MPhil to PhD. So I had a 6-month interruption until I was appointed to a consultant AHP post, and my specialty was then major trauma. So I'd moved from elective trauma and orthopedics to major trauma, so I had a completely different specialty. At this point, I was really fortunate to have secured a PhD fellowship through MFT, which gave me the funding to then progress onto my PhD to finish that off. So that was after the six months of interruption. So I then stepped back into my academic route, and we did ReHIP 2. So the evidence from ReHIP 1 suggested that actually there are enough patients adhering to what we're recommending for us to we can't just we can't just say that we're changing, we just need to get more evidence because it wasn't yet there. So stupidly, I decided to do a multi-centre randomised control trial with one-to-one randomisation, and anybody that has experience of research will know that is a huge undertaking for a PhD, by which time I had 3 years to do it, part-time. We had two groups of 122 patients, routine care group following precautions and a treatment group without precautions. And we didn't use dislocation as the primary outcome, which would have given us the 4,500 sample size. We used Oxford Hip Score EQ5D, which was a quality measure. The Oxford Hip Score is a functional measure. And we also looked at patient experiencing anxiety, satisfaction, and pain. And we used the two time points of 6 and 12 weeks. So the results. Unfortunately, the data was not normally distributed, so we established that using a Shapiro-Wilk test. So we used non-parametric testing of the Mann-Whitney test to assess for significance. So we found that there was statistically significant difference between Oxford Hip Score at 6 weeks. And then the pain numerical score was also significant at both 6 and 12 weeks. Now, patients in the treatment group performed better and had better experience than those in the routine care group, which was that was our hypothesis. That's what we were thinking would happen. What we didn't expect to happen was the anxiety in the treatment group that weren't following precautions was higher than those following precautions. And that was because patients felt that this was tried and tested. They'd been doing this for 60 years and now you're telling me not to do this. And they were anxious about that. So we decided if we did need to do another study, we'd have to do a little bit more wraparound support for patients. In terms of the minimal clinically important difference, again, there was a difference between the two groups, Oxford Hip Score and EQ5D at 6 weeks, and then EQ5D also at 12 weeks. So feedback from patients in the routine care group. So these were the patients that did follow precautions. They were really happy to get to 6 weeks. I didn't sleep properly until then because I had to sleep on my back. It's always a feature, the sleeping on the back. Patient 42, I was happy to see the equipment go. So that was at the 6 and 12 week mark. And then patient 78 felt that it could have done more than they were allowing me to do. So again, they felt that they were held back. In terms of the no precautions, patient 6 had had a previous hip done years ago, and the precautions were a nightmare. So she was up for doing the study, so she didn't have to follow the precautions, which was quite refreshing. Patient 26 was worried about dislocating, and this was a patient that needed quite a lot of support. We had a 7 till 7 telephone contact 7 days a week for this group of patients, and this patient was particularly worried about dislocating. Patient 54, I was back at work at 3 weeks and back at golf at 4 weeks so they're back at work in no time, and even the doc was surprised and they felt that it was absolutely brilliant. And ordinarily, these patients wouldn't be going back to work for at least 12 weeks, so that's a huge impact. So the implications, we've just mentioned the impacts on patients, so we won't need to go over that. In terms of efficiency, just by reducing our length of stay in hospital by 1 day, we can potentially increase the bed capacity for 150 more patients per year to have hip replacements just at MRI, just at MFT. So when we look at that more broadly across the whole of the NHS, that could be another 130,000 total hip replacements could be performed if we freed up that additional bed capacity. And when you think we do 126,000 per year, that's doubling our activity, which is phenomenal. Think about the waiting times we now have for patients. Again, it's gone back up to a year after COVID. So this would be a huge impact. In terms of waiting time for surgery, as I say, our patients are now waiting for a year, which certainly has an impact on pre-op deconditioning because patients are becoming more unwell. Equipment costs, we can save £156,000 per organisation for 300 patients, which if you extrapolate that across the whole of the NHS, that's 135 million, which is phenomenal. In terms of staff, it releases staff for bedside care. It improves confidence of staff because they know they're working to best practice. It empowers them. It makes us an attractive employer. It improves employee retention, and it also improves staff satisfaction. From a socio-economic perspective, you can see that patients were going back to work much earlier, and it also returns patients back to care and responsibilities as well. It also optimises health and reduces the economic load of long-term conditions. So it's got huge benefits across the patch. So the recommendations from REHIP 2 was, do we need REHIP 3? Oh, lordy, lordy. That was a huge sample size again, so we were going to actually be brave and do that. Or do we just de-implement routine precautions from practice and then just monitor as we go along? At a similar time to we were having these conversations and the completion of REHIP 2, the Mitchin paper was published, which identified that removal of precautions following total hip replacement did not actually increase dislocation rates. Which was fantastic. And then GIRF, so the Getting It Right First Time teams, reviewed all the evidence, including REHIP 1, REHIP 2, and also the Mitchin paper, and they decided to recommend that precautions were no longer advocated. So what do we do now? So here we started in January 2025 with the de-implementation of precautions at TESH, MRI and Wythenshawe. We've had really good response. We've had no confusion because we've done a huge educational programme for everybody. And we've just got one surgeon that's a little bit testy, but we're working on him. It's a reduced length of stay already, and it's helping us build a business case to support other services that we need to improve. In summer of this year, we're then going to roll out to North Manchester, and we've got a couple of groups, nationally and European groups, that are also looking at using our methodologies to implement and de-implement precautions. And obviously we'll publish and disseminate across conferences. So that's my PhD research element. But at the same time all this has been happening, I was also appointed the MFT CSS Divisional AHP Research Lead. That's a mouthful, isn't it? So my primary role here is to build capacity and capability for AHPs across the organisation to deliver the research agenda. So the way that we've been doing this is developing the Research Champion Network, and that includes what was previously the Manchester Clinical Academic Centre and is now Manchester Catalys, our Early Careers Researcher Network. We do education, we roll out the HP Roadshow, we have a symposium and a showcase annually now. We introduce webinars, mentoring and supervision, dissemination of the work that we're all doing and findings of all our fantastic research. We do workshops, we do abstract idea sessions, and we do abstract writing sessions. We looked at activity monitoring and reporting, study development and support, and also development of some new roles. And the performance, the outputs from those are, from a Research Champion Network, we now hold monthly meetings, and we've got really active Research Champion and Research Associates across all of the sites now. We've held 2 workshops for our advanced clinical practitioners. So we've educated 63 of those that have now resulted in 3 current projects developing into research studies, and we've had 1 AHP student research placement from one of the local HEIs, and we've now had education has now been introduced to our AHP Research Champion Network meetings. In terms of the, as Jude mentioned earlier, we now have an early careers research, so the pre-doctoral team we are now. So they have, so I'm the lead for that, and we have bi-monthly meetings of 26 members. We have 2 chairs who are both now coming to the end or have just completed their pre-doctoral fellowships, and both of those are submitting doctoral fellowships this year. We've had 2 NIHR PCAF applications in progress and submitted this year, and we've had 3 internships awards through that group. And we've had 1 NIHR pre-application support award also through that group. Our symposium last year, we had 190 attendees, AHP attendees, 89 submissions of abstracts, and we had 78 posters with 4 podium presentations and 2 webinars to support that. We have an AHP roadshow, so we go out on the road regularly. So we do engagement events. We've had 5 site engagement events now, which is 160 staff with excellent feedback, and we've got the next 2 following in June and September. We've just launched our new activity monitoring and reporting. So this is a new system whereby we're tracking all of research activity, but also improvement activity across the organisation. And that went live in April of this year. And we've also had some really exciting developments recently with 2 research and innovation band 6 AHP secondments, which are due to start in June. 3 AHP research assistant secondments, and we've also had 3 submissions for the NIHR DRL, so the Development Research Leaders Award, in 2025. So we're expecting news on that in June. So that's part of my research role. So you can see here, we're climbing that mountain. We're now up to 2018 and we're just getting to the steep bit here. And this is the point at which I became a consultant. So 2017, that's when I was appointed. So I then had not only the trek from the elective side, I also had the trek from the major trauma side as well. So this made it really quite challenging. So then I had to start looking at major trauma research as well and developing a portfolio in that area. So the studies that we've completed, they're the bottom 5 there, so they're the green and they're all completed, writing various different levels. So some are published, some are in write-up, and then some are just submitted for publication. And then we've got a number of active studies or that are in the process of being submitted for and waiting for green light, etc. So I'll just give a brief outline of 4 of the main ones here, which are very interconnected. So we have properly, which we're just writing up at the moment, and that's a qualitative, and we're writing up the qualitative paper and we're just doing the quantitative analysis. We've got a major trauma outcome set study and then a mantra study and the health style. So I'm just going to go through those very, very briefly. So the properly study is based over at the Manchester Institute of Health and Performance, and it's embedded within the Major Trauma Enhanced Rehab Service, which has been developed in collaboration with Nuffield Health, Manchester University Foundation Trust and the Northern Care Alliance. So the programme is based is provided by NHS staff, and it's based on sports and performance therapy theories as well as NHS theories as well and philosophies. And it's an enhanced elite interventions and biomechanical education based over at the Manchester Institute of Health and Performance, as I say. This programme involves 2 sessions of enhanced rehab per week, and this can be up to 2 hours per session, but up to 6 months depending on the individual need of the patient. And this is an MDT piece of work, so it's a service that includes physio, OT, sports and exercise med, consultant orthoplastics and gait biomechanics with psychology as well. The Properly study is embedded within the service. And this is a prospective cohort study of the impact of major trauma enhanced rehab service versus standard NHS care. And once the patients are discharged at the 6-month period on completion of treatment, they're then followed up for 12 months. And the interim evaluation is currently taking place. So this is the metrics. I'm not going to go into detail with this. This is the metrics. This is our patients are so generous with their time and their energy. Considering they've all had major trauma, they are subjected to a huge data set of data collection, which is detailed on the slide. And effectively, what we've found is that the MTERS programs, the enhanced rehab, has seen a significant improvement in the gains in performance and well-being of our patients. So objectively, there's been clinically meaningful improvement in 96% of the measures. From a subjective performance improvement perspective, there's 77% improvement in measures. And then the clinically meaningful improvement in anxiety and depression is 75% in the measures. And we've also looked at the social return on investment, because this isn't a long-term, this is not a substantive service. This is currently running on projects and goodwill. So we have to do a social return on investment to see whether or not this is actually beneficial to, is this cost effective and is it beneficial to us as a healthcare organisation, but also the wider population. And we can see that for every £1 invested, we get £3.43 back. Just some objective scenarios there, and regarding the benefit of the financial benefit to us as an organisation in the wider healthcare environment. So it's hugely beneficial. In terms of the data, in terms of what patients say, there's lots of patient stories out there. You can Google Manchester bombing and you'll find Paul's story, and then we've also got, if you Google Nuffield Health and MTERS, these patient stories will come up, and they're, as I say, they're very generous with their time. So stories here, and the feedback from patients is longevity is key for me with my type of job. You guys and the work that you're doing will probably put another 10 to 20 years on my career. Next one is, I'd say for me specifically, from where I could have been to where I am now, we're literally taking decades of quality on my life. That's a huge thing to give someone, so I really appreciate it. And then this final one, I've come a long way since September when I wanted my leg off. This was a chap that wanted an amputation because his leg was so painful. He kept his leg and he feels like he's got his freedom and his life back. So that's one of the studies. When we were looking at what metrics to include in the development of the MThis program and what we wanted to assess patients to see what was beneficial for them and what our treatment interventions, which was the most effective, we really struggled because there's over 300 measures that are used and there is no specific core outcome data set for measurement of improvements in major trauma patients. So this is the next study that we're embarking on. So this is development of a major trauma core outcome set. So this will steer us into which outcome measures we should be using to evaluate the outputs and the outcomes of the interventions that we're delivering. So this is a huge project, and this is going to be somebody's PhD that we're just in the process of submitting a PCAF for, and we will eventually do the doctoral fellowship as well. And this consists of 5 work packages. It's looking at current scope of practice nationally to see who's doing what and what measures are effective. It has focus groups embedded within, and then we'll progress to a Delphi study. And then we'll look at piloting ultimately the core outcome set that we've decided to use. And hopefully this will help us develop a set of measures that can be used across the whole of the major trauma population. We've then got some comparisons, and it will help us develop research questions, but then also answer the questions as well. And we'll do that through using the mantra, which is another study that we're setting up alongside the COS. So we're setting up the database as we speak. So this is in the process. So we're just finalising the documents, and we've waiting for approvals. This will be a repository of all the data set of the outcomes that will, from the COS data set will go into the mantra. So once we've decided, so for instance, if it's an EQ5D that we decide is the best measure to use, or one of the best measures, that will go into mantra. If we decide Oxford HIP for patients that have had hip problems, that's also part of the COS. So it's a data set. It's a group of sets, a group of outcome measures that can be used for this patient set. That will then go into the registry, and then that will be a repository of data for us locally, but then also nationally, so other organisations can ask for access to the data. So this will help us support network developments and service specification, because we can then identify which are the most effective interventions, and it will also enable us to look at real-time clinical services and improvements across the patch, across the whole of major trauma, which we currently don't have. There's no access to real live data sets at the moment, so we're not very agile and flexible in terms of improving services. So it will enable us to map across. So in collaboration with the MThis program, we also have the health styles study that we're now embedding. So this is in collaboration with Manchester Met, and this is a psychosocial strategy which improves health outcomes. So this is to reduce health inequalities, improve the utilisation of resources within healthcare. And what we find is with increased diversity, we can better understand individual traits and also individual motivations, and it's crucial for secondary disease prevention and maintenance of long-term health. So what we will be doing is separating patients out into their different it's like a bit like having a leadership style or a learning style. You have a health style and how you approach your own health. So we'll be dividing and segmenting the population into the 5 distinct categories, which will help us help clinicians understand how to treat each individual person depending on how they view their own health. It facilitates personalised care, and it also facilitates health engagement and retention of those new learned behaviours of patients to offset, to improve long-term behavioural change and therefore improve long-term health outcomes for patients. All this will lessen the health inequalities and treat patients and people according to the way that they see themselves and their own personal drivers, rather than the condition that they have or their injury. So this will involve recruitment of patients. We're going to do some qualitative analysis using focus groups, and they're going to be mapping the focus groups and the data across, and mapping the patients' pathways and the individuals, and then also looking at the service evaluation of the health style study. And these are just the different styles that patients have. So health conscious realist, balance compensators, hedonistic immortal, unconfident fatalist, and then the live for today. So they're the categories that we have of individual patients. So all of this work has quite recently, we've had a number of awards that we've won. So we've recently won the HSJ award again, which was very recent. So that was for the most effective contribution to integrated healthcare. So that was fantastic news very recently. We also won a prize at the European Federation of orthopedics and traumatology, and that was for outstanding abstract and presentation at presenting in Vienna. And then we're just about to go down to the Advancing Healthcare Quality Awards in that's next week down in London. So hopefully we might be coming back with some more hardware there. So what this illustrates, there's so much work, and research is a team event. This isn't, one person cannot possibly do all of this, and it's a team event. And these are just some of my collaborators that are on the screen here. So there's a huge amount. You know, at one point you might be doing the heavy lifting. At some points you might just be, you know, having a nice leisurely walk at the back. Sometimes you're at the top of the mountain and you're throwing your fists in the air. So that's when we're down at picking up the awards. So it's a team effort. And I think the final thought for me is you can't impose change on anyone and expect them to be committed to it. This is a team effort, and we all have to have that one voice and that shared vision. And it's really important to share your vision, develop your purpose, your shared purpose within the team, engage with everybody, and lead and motivate together. You cannot do it alone, but you can do it. You just have to work together as a team. And I am so immensely grateful for all the team that are around me that help me deliver on everything that I do. And that's my final thought. There are some references, so when this goes out for sharing, I'm happy to send those through as well.
Thank you so much, Justine. We have just a couple of minutes for questions. If you have any questions, please post them in the Q&A, or failing that in the chat, and we'll put them to Justine. Thank you so much for that, Justine. That was absolutely fascinating. It sounds like such a journey as well. And I guess, you know, a couple of questions that I was coming up in my mind as you were talking. It sounds like a real journey that you've gone on. And I was wondering, back in those early days especially, what were some of the challenges that you faced as you realised there was this problem and that you wanted to take it on through an evaluation and kind of research approach?
I'd say one of the biggest challenges was finding the time, which was a huge challenge. And I think, you know, everybody on the call will certainly be able to relate to that. So it was finding the time. So that's when the funding and the fellowships was really, you know, instrumental, because that gave me the time to do it. So that was hugely beneficial. I think one of the other challenges is persuading others and creating that shared vision. It was bringing people along that didn't want to come along. So those naysayers that are saying, not on my watch, they're not happening to me, they're not coming, and being told that one of the real challenges was real strong beliefs of others that if my patients follow this pathway, you're going to cause them harm, and I'm not happy about that. And then one of the other comments was that patients are stupid and they need to be told what to do. So I can't possibly explain my response to that one. So they were the real challenges that I found. And I think, you know, by sharing the experience, putting the patient voice in the centre, and when you can go back to the consultants and say, well, this stupid patient that you think is going to do stupid things and therefore come and back have a hip dislocation, what makes you think they're going to not be stupid just by the fact that you're telling them to follow precautions? So it was, you know, there've been very challenging conversations, and I think that's where my skills of being able to influence people, you know, not necessarily take it personally when somebody doesn't want to do what you're asking them to do. Don't take it personally. easily. That's because you've not connected properly, or there's information that you've not shared with them that might bring them on and help share that vision. So I think they're the two challenges I would say, is finding the time and getting that shared purpose and that vision for everybody to come along and join your team.
And what about at a personal level? So it sounds like, trying to influence people, arguing the patient voice, being persistent from the sounds of it is really important. I guess I know myself, it can be quite an emotional journey too. Can you speak to that? Like, how did you feel and how did you manage that at the time?
Oh gosh, well, this has been an emotional roller coaster, I can tell you, especially when I was, under the impression I had continuation funding to go from MPhil to PhD, and I found out literally it was the 16th of December I found out, as the next NIHR window closed on the 16th of January. So I had 4 weeks over a Christmas period to submit something if I was going to continue. And I was absolutely devastated. I was so demoralized. And I just thought, if I step off this, I'm not going to be able to generate any traction. I'm going to really struggle to get going again. I've just got some momentum. So I found that really frustrating and quite upsetting. However, reflecting back, because I had the 6-month interruption, it actually gave me a bit of time. And I never like to dwell on the negative. I always like to see something positive out of what had happened, and that really was a positive thing for me, because it gave me some recovery time and gave me some time to readjust and think about how I'm going to tackle the next stage if I did get that funding. Then obviously I was elated when I got my consultant post, and then again I was elated when I got my fellowship. But then it's like, oh gosh, now I've got to pick it all back up again. I've now got to get that momentum again. So it's just been, and that the mountain that I've used as as a pictorial representation really of how it has felt, and getting to the top, the flag when I got the PhD was just absolutely fantastic. But then it's the what next, because you just want to walk away from that, and it's easy to walk away. But it's like, no, we've got to do the what next. We've got to implement. We've got to get to that next bit. So again, it's that journey of the ups, the downs, picking yourself up, going on and forging ahead. But I think the one thing that's really helped me immensely is having a really good team around me, and people that you can go to for mentorship. If you're having a bad day, you know who to go to. If you're having a good day, you know who you can go to. And I think it's been really difficult. Family, again, has been hugely supportive, and I couldn't have done it without the team and the family around me that I have. There's been tears, there's been blood, and there's been lots of sweat, but it's all worth it when you see the benefits to the patients. And now when we see the patients are going home on the same day certainly within 24 hours, and some are asking to go home on the same day of surgery, which is just a position I never dreamed that we would be in 10 years ago. I would never have dreamed that. And major trauma, our patients, I remember the first ever major trauma patient that came in. And I saw him 12 months after he was discharged, and his life was just awful. He didn't leave the house. The only friend he had was his cat, and he was in a really bad position. And that's when we started with the major trauma, developing the rehab services. And when I look now at the impact of a young man that wanted an amputation of his leg, and by implementing the MThil service and evaluating that and justifying the benefit, it's hugely rewarding. And now when I watch the videos and the patient testimonies, it brings me to tears often. It's fantastic. So I have every range of emotions are experienced on certainly a weekly basis.
Sounds fantastic. I mean, it sounds like it was really challenging. And I know anytime you want to do something different, that's a risk. It takes a bit of energy, and it can be really hard, I think, in big organizations. We have one question, which I will make our last question, given the time. So this is, how have you found it taking 2 different paths and trying to juggle the challenges of that while maintaining your personal time?
Oh, wow. Good question. I would say I am an expert juggler. I have, over time, I have learned to set very clear boundaries. And we have, with lots of negotiation with my teams, people around me, and also my family. They appreciate when I can be more present and when I need to back off. and they really value the time, team and family, really value the time when I'm present. But if I back off, they know it's for very valid reasons. And it's just setting expectations of others. And I think setting expectations of yourself and keeping to your boundaries. It's not that they can't be flexible, they can, but people know if I say I'm really struggling and I'm pushed, you know this, Jude, I'm really pushed and I'm really going to struggle to take that on. They really value that and they know to give me the space. And it's just being firm with yourself, being realistic with yourself and your own expectations, and then that will filter out and people will respect that and have realistic expectations of yourself as well. And it's just being good at time management and learning the skills as you go along.
Fantastic. Thank you so much, Justine. There's lots of comments in the chat, so do take a look at those when you get a moment. I think reaffirming what we all see, which is that you are a really inspirational leader, and we're very lucky to have you at MFT. So I'm just going to close us there. So thank you so much again, Justine. Really appreciate you taking the time to talk to us today. Thank you so much for everyone who has joined as well. Fantastic to have you. And just to signpost you, this talk will be on YouTube. We have lots of other podcast episodes and talks there about careers, covering this kind of stuff, giving this kind of advice. Please do like and subscribe. It really helps us. And if you are from MFT, please join and you will get regular updates and also information about future seminars. So thank you, everybody.
Thanks, everyone.